Baby born by normal vaginal delivery was pale and floppy at birth. No respiratory effort. Heart rate is respiratory 20 per minute. 5 inflation breaths given with adequate chest expansion. Baby was reassessed, and there was only occasional gasping. Heart rate was 40 per minute. What's the most appropriate next step in the management?
So what do you think the correct answer is?
I thought give 15 ventilation breaths.
What do you think the correct answer is?
I marked it as giving 15 ventilation breaths as there is adequate chest expansion.
So what do you think correct? Is the number one correct? Five ventilation breaths?
Ventilation.
Everybody can hear.
No, and
Anybody can answer. What do you think the correct answer? Anybody can only. Comment on the answer. What is the correct answer you think?
E.
Sorry?
Last one, E.
B. E.
compression.
Yeah. Why chest compression is the correct answer? So I think that is the correct answer. Why do you think? Can you rationalize? Can you explain?
Heart rate is 40.
Yeah.
It's less than 60.
Yeah, it's less than 60. So what is the other reason?
And the 5 inflation breaths were given.
Okay. If you sort of, if you take the other way around, what are the indications for chest compressions in this type in this scenario? So what are the chest compressions? You are given 5 inflation breaths now, 5 inflation breaths, and still the heart rate is 40. So what are the indications for the chest compression? So
chest expansion has been achieved.
Yes, good. So you have given inflation breaths, and now the heart rate is 40, which is less than 60, and chest expansion is achieved, so which means the lungs are expanded. So those two are the two indications for chest compressions. So the correct answer is the last one, and obviously baby is not breathing, so you need to give ventilation breaths. No? That is because lungs are expanded. Otherwise, you need to go back to inflation breaths. No? So the chest compression, the ventilation breaths with bag and mask ventilation is the correct answer of this question. Okay. So what you need to remember is indication for chest compressions in a scenario is one is chest expansion with inflation breaths, and heart rate is less than 60. Shall we go next one?
Comparative.
So can you comment on the second one? Mhm.
6-day-old neonate was brought to the hospital following bleeding from the umbilical stump. The baby was delivered at a teaching hospital. On examination, there was petechial rash on the body. Rest of the findings are normal and the baby was well. Investigation findings are as follows: hemoglobin 18, platelets 220, prothrombin time 60 seconds, activated partial thromboplastin time is 90 seconds. Most likely causes A. DIC, B. hemophilia A, C. autoimmune hemolytic anemia, D. von Willebrand disease, and E. Vitamin K deficiency. 6-day-old neonate with petechial rash. And rest of the findings are normal. Both prothrombin time and APTT are increased. Since it's 6-day-old neonate, most likely answer is hemorrhagic disease of the newborn, so E, vitamin K deficiency.
So how do you want to approach this question to get the answer? What are the salient points here?
6-day-old neonate brought to the hospital following bleeding, so has been discharged.
Yeah, so that is the history, no? But if you want to get the answer, you need to interpret the investigations. So the most two ingredients, prothrombin time and APTT. So what are the arms in the cascade that is involved, and then what are the causes, what are the factors in those arms? Both prothrombin time and APT to be get prolonged, you need to find out the factors involved in that arm. Extrinsic pathway and intrinsic pathway, and there's a so does vitamin K fit in there?
Vitamin K deficiency affects factors 2, 7, 9, and 10. So it affects the
Yeah, I'm not very good at this pathway, but we have to make sure that the prothrombin time and APT are both affected by this whatever the one either one will run. Because first three answers are obviously wrong. It's not DIC, so it's completely out. It's not a septic baby. It's not hemophilia, it's completely out. It's not autoimmune. So the answer is between the von Willebrand disease and the vitamin K deficiency. So you need to find out extrinsic, whether it is extrinsic pathway, intrinsic pathway, and there's a common pathway below that. So what are the factors involved, and then decide on the answer. So what do you think?
Vitamin K affects factors 2, 7, 9, and 10. So it affects the extrinsic pathway.
Can anybody remember the path?
So vitamin K dependent ones are 2, 7, 9, and 10. 7 is included in the extrinsic pathway, so PT can be prolonged. And 9 and 10, 9 is in the intrinsic pathway, so APTT can be prolonged. So I think it's vitamin K. One Willebrand has effect on the vitamin, not the vitamin, factor 8. So extrinsic pathway prolongation cannot be explained with that. PT prolongation cannot be explained. I don't know whether I'm correct. I think so.
Yeah, probably you had things like in that line. So I1 Willebrand is unlikely. So it's probably vitamin K deficiency. You need to always go through the clotting cascade and then and see whether you can fit in vitamin K deficiency into the scenario. So it's probably, I mean, you can judge, you can have an intelligent guess because a 6 days old baby bleeding from umbilical stump. Again, it's a vitamin K deficiency is common, but even 1 milligrams you can have a umbilical stump. That is one of the presentation, 1 milligrams presentation. Okay, good. Shall we move on to the next one?
Well, yes, sir, don't babies get vitamin K megadose?
Yeah, this is, they are not mentioned whether it was given or not. No?
They said major teaching hospital.
Teaching hospital. So teaching hospital doesn't mean that everybody gets the vitamin K. Ideally, yes.
Next one. Go the here. Around another.
Somebody can.
An 18-month-old child presented with skeletal deformities to a pediatrician. On further inquiry, the mother has had fever and a rash during the first trimester of antenatal period. What is the most suitable investigation to find the cause for deformities? A. Torch screen. B. Liver functions. C. Urine for reducing substances. D. Ultrasound scan abdomen. E. Liver biopsy. I thought it's a torch screen.
Okay, good. So why torch screen? Okay, just leave the torch screen for the time being. Is liver function, why do you think liver function is not a possibility?
Baby is having skeletal deformities. I thought it's most probably due to congenital infections because there is a history of maternal history of antenatal infection, and so therefore,
yeah, probably the torch screen is the correct answer. What is out of the torch? Which diseases likely to cause skeletal deformities? What is TORCH stand for, and which diseases likely to cause skeletal deformities?
TORCH stands for toxoplasmosis rubella.
Yeah, can it cause skeletal deformities, toxoplasmosis?
Mostly it causes chorioretinitis and
yes. Chorioretinitis and rash. O stand for
blindness.
No, I think CO is close together, no? TORCH.
Other two, right?
Others. R stand for
rubella.
Rubella. Can rubella cause skeletal deformities?
Yes.
Yes.
What type of skeletal deformity? Does it cause skeletal deformities or does it cause period? What do you call period? The inflammation of the bone, osteoarthritis name or something like that. I can't remember.
Sir, rubella causes mainly patent ductus arteriosus and cataracts, and bone skeletal deformities are commonly caused by syphilis. And
Syphilis.
syphilis, yes.
So there is no S here, torch. So when you say torch, 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 there's no S here. So where is syphilis here in the conjunctive?
In O, it stands for other, syphilis, varicella
Yeah, it's
zoster,
for
and
others.
parvovirus B90.
Yes, yes. And otherwise, some people write S also at the end, TORCHS. Or just. So the syphilis, what are the types of syphilis? Early syphilis and late syphilis, no? The two presentations. No? How do you think you can prevent this happening?
Antenatal screening of the mother.
What is the antenatal screening?
VDRL.
You could probably do VDRL. No? How do you confirm the skeletal deformities here?
Abnormality scan 20.
No, now this baby is 18 months old. So you have the baby with you. So how do you confirm mainly now we need to make a diagnosis? No? So you have the skeletal deformities. Do you want to do anything else to support your diagnosis?
X-ray.
Yeah, X-ray. So what does the X-ray show? Can somebody tell us the X-ray findings? Typical X-ray findings of a congenital syphilis baby. I think read about it. There's a typical, I can't remember, there's a typical findings in the X-ray, especially around the bigger joints, no? Like knee joint, or knee joint, the femur and the tibia, there are typical findings. What is the treatment? Treatment?
Penicillin?
Sorry?
Penicillin.
Yeah, it's penicillin, C-penicillin. C-penicillin is the drug of choice. How long? So I think for at least for 10 to 14 days of penicillin. And make sure you have to investigate for the mother as well when you have a child. Okay.
Okay.
Yeah, others are not correct. So that's a straightforward question.
Somebody read the next one. Any volunteers?
A 2-day-old boy was admitted to a peripheral hospital due to poor feeding. On examination, he is dyspneic, respiratory rate 80 per minute. pulse rate 170 beats per minute. Blood pressure in the upper limb is 80 by 55 micrometer and lower limb is 55 by 30. SpO2 94%. What is the immediate management of this child?
Okay, forget about the immediate management and tell us what's going on in this patient. What do
This
you think
child
is
is having
happening?
a duct-dependent circulation, sir.
She said that.
Duct-dependent circulation.
Yes, before you say duct-dependent circulation, this child is in shock.
Yes, blood pressure upper limb 80 by 55 and pulse rate 170.
Yeah. So this child is in shock?
Yes.
Yes. What is the type of shock? When you say type of shock, whether it is hypervolemic type of shock, or whether it is distributive type of shock, whether it is cardiogenic shock, or whether it is obstructive shock. So what do you think?
Obstructive shock.
So what is the what is the likely type of shock here?
With high pulse rate and blood pressure is 80 by 55. Most likely hypovolemic.
Sorry?
With the history of poor feeding also, sir, I think this is a hypovolemic. And pulse rate is 170 and blood pressure is 80 by 55 in upper limb.
No, but I think you already made the diagnosis. No, there's a pressure difference between the upper limb and lower limb.
Yeah.
And 2 days old baby. So what is the most likely diagnosis here, as you said before? Most likely diagnosis?
Circulation is obstructive.
Yeah, it's obstructive type of shock. So what is the most likely diagnosis?
Obstructive type of shock.
The most likely diagnosis here?
Coarctation of aorta?
Yeah, coarctation of aorta, isn't it? The most likely diagnosis is coarctation of aorta. Now, so if it is coarctation of aorta, how do you support your diagnosis? Coarctation of aorta here.
Pressure difference of the upper limb and lower limbs.
Yes, pressure difference upper limb and lower limb. Do you think that this patient was missed before discharge from the hospital? Before discharging from the hospital?
Usually, closure of the duct
No. Any
starts
type
after
of
24 hours.
examination that the doctor should have performed before discharging this patient?
Yes. Yes.
On auscultation, there'll be a continuous murmur. Maybe the doctor has missed it.
Murmur may or may not be there. The single most important sign that should have been elicited before discharging?
Femoral pulses.
Very good. Femoral pulses. Huh? Somebody should have checked femoral pulses. So what do you expect when you examine femoral pulses?
They will be absent or weak.
In comparison
to the brachial pulses.
Yeah, comparison to brachial pulse. You have to always compare the brachial pulse and see. There should be delay or absent femoral pulse. Any other sign that you probably look for in this baby to support your diagnosis?
Saturation differences between the lower extremities
Okay,
and
you
the
can do yes.
upper.
Saturation differences also acceptable. What is the physical sign that you probably look for in this baby? Anything in the abdomen that you look for in this baby? Just think of the hemodynamics. What do you look for in the abdomen in this baby? What do you think? Do you think the liver is enlarged? How do you explain liver enlargement here? So why do you think the liver is important and liver is enlarged in this scenario? Speak up, somebody.
Right-sided.
So the coarctation is basically it's a left ventricular overload, and the back pressure can cause right-sided heart failure as well. So what is the treatment now? Immediate treatment?
Prostaglandin infusion to keep the duct open.
Okay, fine. What is the risk of giving prostaglandins? When you give prostaglandins, what are the important things that you monitor? In other words, what are the complications of a prostaglandin infusion? When you start prostaglandin infusion, what complications likely to happen? If you have the doctor accompanying this patient, what are you going to observe?
Pulse rate.
Sorry?
Pulse rate.
No, not pulse rate.
Hypokalemia and hypotension.
No, already hypertensive. There can be anything less than this. Any clinical signs that you probably look for in this baby? When you start processing, they can get apneic. So we have to be ready with respiratory support in these patients. Okay. Would you give a bolus for this patient? Normal saline bolus B?
Yes, because the respiratory rate is 80 and the patient can excrete a lot of water through expiration, and so he can get hypovolemic as well. So a bolus won't do any harm.
But going through this question, would you think is more likely to be, the shock is more likely to be hypovolemia, or the shock is more likely to be cardiogenic or obstructive type of shock?
It's obstructive type, sir,
Yeah.
but there can be, high respiratory rate.
Okay.
There can be superadded hypovolemia.
Now. So how do you differentiate? Suppose you give a 10 ml per kg bolus to this baby. How do you know whether it is working or whether it is not working? Obviously, this patient is not working, isn't it? Because this is obstructive type of shock. You are going to give a bolus. So how do you know if the bolus is going to make it worse?
Heart rate?
Yeah, heart rate is already high, no? I mean, heart rate can get more than that. That is one of the things. What are other signs? What is the other sign?
Respiratory.
Sorry?
Saturation.
Saturation is very, very subjective.
Respiratory?
Respiratory.
Respiratory also not very, it's very subjective. So basically,
with fluid developed.
Sorry?
Fluid
Yeah, go on.
auscultation.
So
With
auscultation, what do you hear in this baby?
bilateral crepitations.
Sorry?
With pulmonary edema, bilateral crepitations can.
No, that is in the lungs. No, but I'm asking, so auscultation of the heart. What do you hear in this baby?
Gallop rhythm due to heart failure.
Gallop sounds. What are the heart sounds involved in the gallop rhythm?
S1, S2, and S3.
S1, S1, S2, and?
S3 and S4 gallop rhythm.
Okay. Is S3 normal?
In young children, S3 can be physiological.
Yeah, S3 is normal. No? Yeah, up to 40s, S3 is normal. So basically, gallop rhythm is S4. So that is something that you need to look for in this baby when you auscultate the apex. What is the other thing that you probably look for, whether your bolus is not working or making it worse? Other sign.
Basal crepitations was long basal crepitation.
Very difficult, no? When the baby is lying down, small baby, not like seated, no?
Blood pressure?
No, not the blood pressure, no? The liver, no? So liver, you need to look at the liver. So how do you find out the liver is, how do you get, what do you get in the liver when you give the bolus? What will happen to the liver when you give the bolus, 10 ml per kg? Three things, either normal or shrink or enlarge. What do you think?
Enlarge.
Sorry?
Enlarge.
Enlarge. So you are basically supposed to draw the liver line when you see a baby like this. And then even by mistake, if you give too much of fluids, that can get enlarged. So there is something you probably do at the bedside. Okay, any questions on this?
No.
So any takers for this one?
One in another. That's Muru in another. Oh, so silent.
Can one of you take this question?
Lahiru in another.
Yes.
Prashna, please. Thank you.
A 28-month-old premature baby whose birth weight was 1.3 kilograms was ventilated due to respiratory distress and extubated after 3 days. Next day, his blood pressure was 80 by 40 micromillimeter and heart rate was 130 beats per minute. What is the most appropriate management option?
I think this question is wrong. It should be 28 days. It should be 28 days premature baby. So if it is 28 days premature baby and basically 1 month, extubated after 3 days.
Next.
So he was ventilated. After 25 days, isn't it?
Sorry.
Huh?
No, again.
That's what it means. 25 days of ventilation and extubated 3 days back.
Next day, his BP was 80 over 40.
This question is not very clear, but don't worry about the question. So, what are the likely things that can happen? Just forget about the numbers. A premature baby weighing 1.3 kilos is ventilated now, extubated after 3 days back, and the blood pressure is now on the 3rd day after extubation. Blood pressure is 80 by 40 and heart rate is 130. What are the most likely causes? Do you put it that way?
PDA?
PDA, obviously, yes. One of the PDA. So how do you find out whether it is PDA or not? What are the signs would you look for?
Auscultation, the continuous murmur
Okay.
beneath
So,
the left trach.
sorry?
Measuring pulse pressure, it was increased.
Yeah, what is the pulse pressure here?
40.
Yeah, 40. No? This is lichen minus dash lichen. So white pulse pressure, no? White pulse pressure and the murmur. And what else would you look for PDA?
And investigations.
No, clinical signs.
They can have easily palpable pulses, peripheral
Yes.
pulses.
So what do you call that? You call it bounding pulses.
Bounding pulses.
You call bounding pulses. And obviously you can get some liver enlargement with this. No? So then you probably think of PDA. How do you treat PDA?
Duct closure is recommended with immediate closure of the duct.
Sorry, say it again.
Closure of the duct.
How do you close the duct?
Coil or device closure.
Sorry?
Coil, pharmacological intervention method can use.
Yeah, so it's not the surgery, it's not the first option. So what are the medical options available?
Ibuprofen.
Ibuprofen, how do you give? How do you give? IV or oral?
IV.
Okay. So oral is as good as IV. You can start on oral ibuprofen. And if indomethacin IV is available, you can use indomethacin IV. But ibuprofen oral would be a good choice. What are the other possibilities apart from PDA?
Sepsis?
Yeah, sepsis. No? Sepsis and septic shock is another possibility with the wide pulse pressure. So always you need to do test septic screen and antibiotics.
So what is the answer?
So this question is not right. I don't think it's a very good question, but it's not correctly written, I think. On the other hand, if you think that there's a 28 days old baby, premature baby, ventilated up to 25 days and extubated, what is the most likely problem this baby is going to have?
Bronchopulmonary dysplasia.
It's in the last century in bronchopulmonary dysplasia. What do you call it now? ARDS. What is the new name?
Surfactant deficient lung disease. Surfactant deficient lung disease.
No, surfactant deficient. It's all gone. No. Ventilated for 25 days and extubated 3 days back.
Yes.
And still having respiratory distress.
ARDS?
Not ARDS, no? What do you call that? We used to call it as bronchopulmonary dysplasia those days. We don't call it any longer. So what is the new name? That's a new name? Anybody? Heard of chronic lung disease? We call it now chronic lung disease. Just go through the criteria for diagnosing chronic lung disease and management options. Okay, shall we move?
This one doesn't have an answer.
Yeah, this one, I don't think the question is right. This question is wrong.
So oral paracetamol can be given if it is patent ductus arteriosus?
Oral paracetamol, yes, you can use, but it's not a very effective drug for PDA.
Yes,
You can use, but not. It's not. I mean, basically, you had used non-steroidal anti-inflammatory drugs. NSAID.
Excuse me, sir. I have a question regarding the 24th question, sir.
24th question, yeah.
Wonderful, sir. That in that question they say it's a peripheral hospital. So can we still take it as prostaglandin?
Yes, because this we need to. Baby would have been born at teaching hospital or peripheral hospital, but has come to the peripheral hospital. So if you want to keep this patient going, you need to start on prostaglandins. You have to get down the prostaglandins and start on prostaglandins.
Okay, thank you, sir.
Fine.
Otherwise, otherwise you had to start the normal resuscitation like ABC in this patient. But those are not specific management. Like even high flow, you need to start. There's no question about it. It's not some IV intravenous cannulation, and probably you may have to give a normal saline bolus, but you should know how to monitor this patient. And patient is bad, you have to start on intubation and everything, but those are not specific management. So in a single best response answer, we want you to choose and pick and choose the correct, the most likely specific answer.
Okay, sir. Thank you, sir.
26.
Anybody wants to take this?
No volunteers? Namak කියන්නද?
What do you think is going on? Anybody?
A child presented with stridor while crying since 3rd week after birth. His feeding is satisfactory. No other abnormalities detected on examination except for an inspiratory stridor. Most appropriate management option is
Don't worry about the management. What do you think is going on with this patient?
Foreign body expiration.
Foreign body.
Think third week baby, foreign body aspiration. What is the foreign body?
While breastfeeding, breast milk aspiration.
There are a few ways of approaching this problem. No, one is this salient problem in this question. Salient issue in this question is stridor. So if you go through the causes of the stridor, and then if you narrow down the stridor that can happen at 3rd week, then you probably might get somewhere. No? If you apply that, what do you think the correct the possibilities? Think about the cause of the stridor and likely cause in a 3rd-week old baby.
Congenital laryngomalacia.
Yeah, it's probably congenital laryngeal stridor, no? Congenital laryngeal stridor. And what do you know about it? So that's mainly an inspiratory stridor, congenital laryngeal stridor. So how do you want to treat?
It will spontaneously resolve.
Yes, spontaneously resolve. So what do you want to tell the mother?
The baby is fine. It should disappear within 1 month, and if it persists to come back.
Yeah, how long it takes to clear? So it's congenital laryngeal stridor, and so the correct answer would be the C, no? Reassure the mother. And mother wants to find out how long it takes to clear. Anybody would like to give a time limit? No? So it's probably around 1 year. Okay. So the others are, all the others are not appropriate. So next one.
Can it be any other causes at 3
Yes,
weeks?
what are other rare causes that we call 3rd-week? If it is not congenital laryngeal stridor, what are other causes?
Croup.
Croup is a viral infection, no? It's not likely.
So could it be adenoid hyperplasia?
Yes, could be could be hyperplasia. What else? What are other causes?
Fistula.
Yeah, it's probably can be fistula very rarely. And
Epiglottitis? Epiglottitis?
no, epiglottitis not likely. In 3rd-week baby, epiglottitis is likely in bigger babies, about 2 years. That's how you differentiate croup and epiglottitis. No? So this is a 3rd-week old baby. No? So every 3rd-week old baby doesn't get epiglottitis. So congenital laryngeal web and fistulas, arteriovenous fistulas, all these things, and some physical obstruction. Just go through the book. There are other causes that can happen, likely causes. Yeah.
No questions, Nick?
Excuse me, sir. So in that case, cannot we go for bronchoscopy to identify the cause?
Sorry.
Microlaryngoscopy.
No, microaneuryscopy you can do, but you won't do as a first option. And it's not the most appropriate answer.
Is there any indication for?
Indication again, if you think it's not congenital laryngeal stridor, yes, then you will go for that. But it's not the first choice.
Thank you, sir.
Volunteers in order. Anyone?
A 7-year-old girl was admitted with an acute wheezing attack to the pediatric ward. Her respiratory rate is 50 cycles per minute. Heart rate is 110. SpO2 is 94% on air. On examination, air entry was equal bilaterally and vesicular breathing was heard with prolonged expiration. She has been nebulized 2 times with salbutamol within an hour and at the outpatient department. What's the next step in the management?
So what is happening here?
This is a patient with asthma, and this is likely to be acute severe asthma because the respiratory rate is 50 and the heart rate is also high. But SpO2 is 94. And she's not responding to nebulization. So the next step would be...
Yeah, so is this patient is having acute severe asthma or life-threatening asthma?
Not life-threatening, sir. In life-threatening, the respiratory effort is reduced and the heart respiratory rate wouldn't be so high and it will go down and there'll be silent
Remember any
chest.
cutoff lines between life-threatening asthma and acute severe asthma? Cutoff numbers?
I don't know, sir.
Okay, so just go through. There's a cutoff numbers for acute severe asthma from life-threatening asthma. So, so this is acute severe asthma. So what's happening here?
She's not responding to salbutamol alone.
Yes.
So the next step would be to add ipratropium bromide.
Yes, the next thing
solution.
is to add ipratropium bromide and salbutamol plus ipratropium is another option that you probably wouldn't consider. No? What else?
Yes.
What are other options that you can think of? Which is not given in the answer.
Oral prednisolone is also indicated.
Yes. So would you give oral prednisolone or IV prednisolone, IV hydrocortisone?
IV hydrocortisone.
Why? How long does it take to act?
IV hydrocortisone takes time, about 1 to 4 hours.
Like about 4
about
hours.
4 hours.
So you need to, whatever you give the steroids takes 4 hours. So you need to give early if you want to start on, if you want to have a response, you have to start the steroids very early. Any complications that you probably look for at this stage? There are other complications that you probably look for in a wheezing patient.
should look for an infective cause of exacerbation, like there'll be crepitations or signs of a consolidation. There may be pneumothorax, community-acquired pneumonia. So,
what is community-acquired pneumonia? What is most likely community-acquired pneumonia? That
streptococci?
No. That the wheezing patients present. Atypical organisms. What are the atypical organisms that can?
Mycoplasma.
Mycoplasma, yes, mycoplasma. Okay, so that is the infection. But anything else, any other complications that you can think of? Now, this patient's been nebulized. It's albuterol and then iprapropium bromide, started on steroids. The other complications that you probably think of when you manage this patient?
Pneumothorax should be looked for, but
okay, pneumothorax is sudden deterioration. This patient has not there's no signs of sudden deterioration. What are other complications? What happens when you have a high respiratory rate like this? What does
dehydration?
Dehydration, obviously, dehydration. So you probably want to assess the state of hydration in this patient and then correct the hydration. That is one thing that you need to look for. What is the other thing that you need to look for? What are the other complications that you probably want to look for? What happens when you nebulize with repeated doses salbutamol?
Hypokalemia?
Hypokalemia, yes. Hypokalemia, low potassium. No? So you need to check the potassium status in this baby child and then try to correct it later on.
So the answer is D.
Answer is probably D, no?
What is the test for mag sulfate infusion?
Yeah, mag sulf indication is you are given nebulized with salbutamol and iprapropium, you are given steroids, and then your next step is either mag sulf or salbutamol IV.
Any questions? No? We'll do next one. Any volunteers? Can you come in? Akalam තියෙනවද? මන්ත කෙනෙක් volunteer කරන්න. මාලන් ඉන්නනේ. මාලන් No volunteers.
Somebody summarize this question.
Seven-year-old boy was taken to the emergency unit by his class teacher after an accidental collision with his friend. He had fallen on the ground and the head had suffered an impact, after which the teacher had observed the child suddenly become pale and develop jerky movements on his upper body that lasted only for 2 minutes. His mother stated that the child had a similar experience after receiving the MMR vaccine at the age of 9 months. The clinical examination was unremarkable. Child was well and conscious. What is the most important next step in management? A. Admit and start head injury observation chart. B. CECT. C. EEG. D. Arrange ECG. Or E. Reassure the mother.
Okay, so what do you think about this one? This one, do you think this 9 months incident and this one is connected or not connected?
Could be connected, but
Any other opinions? Connected or not connected? Shout, somebody.
but no live vaccines at 7 years.
What do you think?
This can be a vasovagal attack.
Yeah, could be
Due to
yeah. Why do you think it's a vasovagal? More like to be vasovagal?
Because the patient has become pale,
Yes.
and suddenly collapsed. There are jerky movements, but sometimes when in vasovagal attacks also, when there's hypoxia, they can get a bit of jerky movements. And this incident, the previous incident, like the babies can get scared of the injections and they can get vasovagal attacks. So the previous history may be due to that. I don't know.
Yeah. So would you think these two incidents are connected or likely to be connected or unlikely?
Unlikely to be connected.
Yeah, it's probably unlikely to be connected. No? Unlikely to be connected. So as you said, you need to differentiate between vasovagal attacks and from true convulsions. So what are the differentiating points? So I agree that the pale color is more likely with vasovagal attacks than fits, than convulsions. But on the other hand, jerky movements, is it in favor of vasovagal attacks? Can it happen in vasovagal attacks? Or it's more likely to happen in convulsions?
It occurs in convulsions, but jerky movements cannot exclude that it's a vasovagal attack, because sometimes with hypoxia, can jerky movements be explained with hypoxia?
Yeah, hypoxia So yeah, jerky movements are basically like, okay, that can happen because of the severe hypoxia, but not immediately, it takes a little time. So what do you want to do in this situation, management-wise?
With the history of teacher observation of head has suffered an impact after the fallen, we have to admit the child and start head injury observation chart for 24 hours initially.
Yeah, probably that is what we should do, no? We don't know what's going on in this patient. Maybe a concussion, maybe some significant head injury, or may not be anything at all. So probably you need to admit and do the head injury observation for at least 24 hours or even 12 hours. And then decide on whether to go for further investigations. Any test that you probably would do, the important test? What do you want to do?
Need to check for both seizure and arrhythmias. Seizure you can do with the EEG.
Yeah, that's planned, no? That is later on. But the immediate or any other basic test that is important?
Look for
Sorry?
eye reflexes, light reflexes.
Basic test means biochemical test.
CBS.
Yeah, blood sugar. Blood sugar is important in this test because this patient has either the extravegal, even if it is a vagal or a conversion. So don't ever forget blood glucose. Now that's one of the top on the algorithms. Algorithm of conversions. So blood sugar is important.
DEFG. Any questions? No one?
Excuse me, sir, I have a question.
Yeah.
So if there was a response like non-contrast CT was the option. Should we go for that? I mean, after 24 hours or something?
Yeah, it all depends on the head injury observation. If the head injury observation shows there's a significant head injury, then probably you have to go for non-contrast CT first. Because if you do a contrast CT, then you might not get a clue. So first go for non-contrast, then you can see a bleed, and then confirm with the contrast CT.
Thank you, sir.
No questions? Next one, next volunteer. Kauda. Somebody.
A 9-year-old boy presented following a seizure on day 3 of fever. On examination, he was drowsy, responded poorly to commands, and his speech was incomprehensible. After excluding raised intracranial pressure, a lumbar puncture was done, and CSF findings were as follows. Cells are 40 per high power field, lymphocytes 30 per high power field, 35 per high power field, red blood cells 25 per high power field, protein 25 milligrams per deciliter, sugar 60 milligrams per liter. What is the most likely cause for his presentation? Acute disseminated encephalitis, autoimmune encephalitis, partially treated bacterial meningitis, T meningitis, and viral encephalitis. I took it as viral encephalitis since the child is drowsy and responding poorly to the commands and with incomprehensible speech. And regarding the CSF findings, high lymphocyte count with normal protein and sugar. So it's probably viral encephalitis.
Can you closely look at the sugar and interpret in this biochemistry?
The CSF sugar is 60 and random blood sugar is 90. So the percentage right is it is 60% from the random blood sugar. So if it is any bacterial origin, it should be less than 60%, and in viral origin conditions, it is usually normal. So
yeah, so you need to interpret the blood sugar with the CSF sugar. No? So CSF sugar is 60 and blood sugar is 90. So it's more than 60%, no? Isn't it? 60 out of 90?
66.
So it's not affected. No? So it's not, so out of these questions, what are things you can exclude? What are things you can exclude?
TB meningitis can be excluded because the sugar levels are CSF sugar levels are normal, and protein is also in the normal range.
Yes, the TB meningitis, the more than the sugar, the proteins are very high. No? So here the proteins are within normal limits. So TB is out here. Anything else that you can exclude?
Partially treated bacterial meningitis.
Why?
In bacterial meningitis also, sugar level should be less than 60%.
Yeah, sugar level is very low, no? So that is also probably out, no?
Excuse me, sir, but in partially treated bacterial meningitis, it is the lymphocyte. It is kind of similar to the viral meningitis pictures with elevated lymphocytes and normal sugar. So.
Yes, there's a possibility, but again, if you sort of think typical partial treated meningitis, it's a lymphocytic count, but sugar should be typically low. So out of the other three, what is the most likely? So what is the most likely diagnosis?
Autoimmune.
Autoimmune again difficult to diagnose. No? Even acute disseminated encephalitis is difficult to diagnose. So possibly you have to think simply at the bedside, viral meningoencephalitis. Because there's not much information for you to say acute disseminated encephalomyelitis and autoimmune encephalitis, so it's probably viral encephalitis.
So how will acute disseminated encephalomyelitis present? Well, or any
Well, that's not
in diagnostic investigation?
that's not a diagnosis that you make straight away. And you need to sort of, you need to observe, you need to examine this patient over a period of time to diagnose it. And also there are lot of non-specific features which is not mentioned here.
Okay, sir. Thank you.
So it's a clinical diagnosis.
Yeah, it's basic clinical diagnosis.
Any other questions? Next question. No volunteers?
A 7-year-old girl presented with her first relapse of nephrotic syndrome. Prednisolone 60 was started. Her urine protein was still 3+ after 3 weeks, but there was no edema or ascites. What is the next step in the next management option?
What do you think?
Self-respiratory relapse. Treatment is given for 3 weeks and still protein positive. But no edema or ascites. So to diagnose steroid resistant nephrotic syndrome, treatment should be given for at least 4 weeks. Continuous prednisolone.
Okay, so one of the option is to continue prednisolone. Is on prednisolone. Need to continue prednisolone. What any other option that you probably think of?
Change to methylprednisolone?
You can change, but you are not making any progress. What is the advantage of methylprednisolone over prednisolone?
There may be gut edema. Therefore, due to that, the absorption of oral prednisolone is affected. So, IV methylprednisolone may improve his condition.
But there's not mention about the IV methylprednisolone. This is changed methylprednisolone. So it can be either IV or. What is the difference between prednisolone and methylprednisolone? What is the basic difference?
Prednisolone is oral and methylprednisolone is parenteral.
Sorry, say it again.
Prednisolone is the oral preparation and methylprednisolone is the IV preparation.
Yeah, can be IV, but pharmacological wise, what are the differences?
Don't know, sir.
Methylprednisolone is more potent than.
More potent, yeah. Why do you say it's more potent?
It's,
Why do you think it's more potent?
the higher dose, the I don't know, sir.
So when you say prednisolone, the prednisolone has two characteristics. No? One is the steroid, corticosteroid effects, other one is the fludrocortisone effect. What does methylprednisolone has? Both or one? And to find out how many times the methylprednisolone is potent in comparison to prednisolone. So just read about methylprednisolone and prednisolone. The methylprednisolone doesn't have a fludrocortisone effect, and it's about, I think, 8 times more potent than prednisolone. But answer to this question is not the prednisolone. What are the indications for levimosol? Number one says add levimosol. It has seen about one trough unit, they normally add levimosol.
Steroid resistant.
Yeah, so one thing you need to read about is what is the steroid-sensitive criteria such as steroid-sensitive nephrotic syndrome and steroid-resistant nephrotic syndrome and indication to add levimosol here. Go and read up those.
So, what is in this patient? So what?
Probably number A.
Is it because patient is not responding to the?
Yeah, so you need to find out the definition of steroid-sensitive nephrotic syndrome that is fitting here. And then whether it's steroid resistance, and when do you call it steroid resistant, or to when what are the indications to add levimosol?
Any questions? No, no longer. Any volunteers?
Five-month-old adopted boy continues to have watery stools for 3 weeks following an episode of acute gastroenteritis. On examination, he is normal other than perianal excoriation. What is the best step in management? A. Change to different brand of formula milk. B. Change to a soy-based formula. C. Commence a course of antibiotics. D. Start complementary feeding. E. Provide zinc supplementation.
So what's going on here? Forget about the answers. What's going on here?
This could be a secondary lactose intolerance following the diarrhea, following acute gastroenteritis.
Would you call this as acute gastroenteritis or chronic gastroenteritis? What is the definition of chronic gastroenteritis or chronic diarrhea? Anybody? Yes.
Chronic diarrhea is lasting for more than 6 months.
Yeah, just go through the definition of chronic diarrhea and see whether this patient fits in chronic diarrhea. So what are the most likely causes in a scenario like this? Most likely causes of
Food poisoning.
3 weeks.
5 months.
5 months, no, going on for 3 weeks now, no?
So the question says, following an episode of acute gastroenteritis.
Yes, so started with the acute gastroenteritis, but
Yeah.
what is school for 3 weeks now?
Can't this be post-gastroenteritis syndrome, as somebody said earlier?
Yeah,
Lactose intolerance plus perianal excoriation is also there.
Yeah, it was one of the possibilities. The post-gastroenteritis, perianal excoriation. Again, when it goes for 3 weeks, you are a bit worried to label it as simple gastroenteritis and going for 3 weeks. But always think whether there are any other possibilities. So what are other possibilities?
Cow's milk allergy.
Sorry?
Cow's milk allergy, because this is an adopted boy.
Okay, fine. Yeah, cosmic allergy is a possibility because this adopted baby and obviously not on breast milk. So the cosmic allergy is a possibility. What are the other possibilities?
Primary lactose intolerance.
This secondary, no? This after gastrointestinal, acute gastrointestinal, like a
Yeah. Sorry. Celiac disease. Unlikely.
Worry, no?
Yeah. If antibiotics were given, can this be Clostridium difficile?
Yeah, but
Antibiotic
antibiotics not given,
induced.
no? But the answer says
It's not
to start
given.
on antibiotic.
Nice.
So there's no record that the antibiotics is given or not. What about the zinc supplementation? What do you think? What is the link here? Why did they put zinc as one of the treatment options? In other words, if I ask you what are the signs of zinc deficiency, can you tell me what the signs of zinc deficiency?
So the guideline says zinc supplementation is recommended as it is known to reduce the duration of diarrhea. And when
Yes.
zinc is given for
Okay.
14 days in advance, it reduces the risk of recurrences of diarrhea for the next few months.
So what are the signs of zinc deficiency?
Diarrhea is also a sign of zinc deficiency.
Yes, very good. Perianal exoration is a sign of zinc deficiency. No? What are other features you look for? In zinc deficiency, would you look for any other signs? Watery stools? No. The child has anyway, baby has anyway watery stools.
Nail changes, eczema.
What about the perioral? Do you get perioral lesions in zinc deficiency? No. Yeah, just read. I think read about the zinc deficiency. So what is the best management step in this patient? Different brand of formula.
Start complementary feeding.
Okay, start complementary feeding, but that is non-specific. No?
Because the child is 5 months old and he is already around the age of starting complementary feed.
Yeah, but that's not going to help the diarrhea.
With the similarity
That
of
will help the.
the
Yeah, go on.
with the similarities of the zinc deficiency and the child's symptoms, what about providing the zinc supplementation, and it will also reduce the duration of the diarrhea?
Yeah, obviously one option we can consider is provide zinc supplementation here. What is the other thing that you probably want to consider here?
As this is taken as a secondary lactose intolerance, so we should avoid lactose giving to the child. So instead of that, we can commence soy formula.
Yeah, probably soy formula is another good option. No? So you need to choose between starting on soy formula versus zinc supplementation. So what do you think the most rational thing?
With the current condition, we can go for zinc supplementation,
But
acute management.
But zinc supplementation is can be given to any diarrhea, and so all those features as given to take as secondary lactose intolerance. So they may think of according to that soy formula can.
Yeah, I also think that the soy formula is the answer here because there seems to be a secondary lactose intolerance, but only thing is secondary lactose intolerance is basically acute event, and 3 weeks, going on for 3 weeks, 3 weeks, still a possibility of a secondary lactose intolerance, which will be helped with soy formula. But I think you need to add zinc as well here. So if you are given the choice between soy formula and zinc supplementation, you probably first start with soya-based formula and then start on zinc. But having said that, this question is perineal excoriation. Perineal excoriation is more in favor of a zinc deficiency. So as far as this question is concerned, I think although it looks soya-based formula, zinc supplementation is the answer for this question. Because of perianal excoriation. So read up about the zinc deficiency. What are other signs? What do you call that condition? I can't remember now. Zinc deficiency causing diarrhea. There's a name for that, no? Can't remember, enteropathic or something. No?
Acrodermatitis enteropathica.
Acrodermatitis and
Oh, I can
say it again.
acrodermatitis
Yeah, acrodermatitis
enteropathica.
Yes, that's right.
no questions, no?
In illustrated, it is stated that a soy formula should not be used below 6 months of age, as it has a high aluminum content.
Sorry. Hello?
In illustrated, it states that a soy formula should not be used below 6 months of age as it has a high aluminium content and contains phytoestrogens. So for secondary lactose intolerance for a child below 6 months of age, can we go for soy-based formula?
You can use below 6 months, even soy-based formula can be used below 6 months.
Illustrated, what was in the illustrated? Can't use.
A soya formula should not be used below 6 months of age as it has a high aluminium content and contains phytoestrogens.
So context.
Okay, so I'm not quite sure about it, but I think yeah, I think the zinc is the most appropriate.
Thank you.
32. Any volunteers? Angelo innada? No. In a monkey one. 14-year-old girl presented to the outpatient department complaining of recurrent abdominal pain for the last 4 years. What is the feature most suggestive of a functional abdominal pain? A. Presence of blood and mucus diarrhea. B. Increase in intensity with acute stressful event. C. Pain localized to periumbilical region. D. Pain relieved with defecation. And E. Pain worsens at night. 14-year-old girl complaining of pains, abdominal pains for 4 years. Recurrent abdominal pains. Functional abdominal pain means there is no pathological cause for the pain. Acute stressful events, I think, are the most common cause for functional abdominal pain in this age group. So the most suggestive feature is increasing intensity of acute stressful events.
Yeah, but only thing is you need to find out whether this, how do you measure the stressful event?
Behavior.
Issue, no? So like, so the number one is out, it's a pathological. Then what about the DNE? Pain relieved with defecation and pain worsen at night. Can we disregard, can we cancel those two? Pain relieved with defecation, is it a likely sign of functional abdominal pain? And worse at night?
Context.
So if it is functional abdominal pain, you can't link the symptoms at a particular time of the day or any other activity. Then it's not functional. So the answer is between B and C. How do you narrow down? How do you choose either B or C?
Check for Check for hernia and
pain localized to periumbilical region is a non-specific. Non-specific and the increased intensity with acute stressful events and is very subjective. And stressful events can be very mild, moderate, and how do you measure those stressful events? So it's not all that easy to link to increase. So I think probably number C is the correct answer. No?
So, but periumbilical region sometimes not in this patient, but
say loud.
So periumbilical pain sometimes relates to the midgut symptoms. So if the patient is getting pain in the same area for 4 years, do we have to be worried?
Yeah, what do you think? The going on for 4 years, periumbilical region, 4 years, a long period. No? So is there a pathological issue? They should have. Somebody should have picked up a pathological problem.
Yes. Yeah, so most probably C then.
Sorry?
Yes, most probably C may be the answer then. So thank you.
Yeah. So do you want to continue or want to do another day?
කට්ටියට මහන්සිද? අපි වෙන දවසක කරනවා නැත්නම් තව එකක් කරනවද? Shall we finish then? Or මේකක් කරනවද?
එකක් කරමු ප්‍රශ්න එකක් කරමු.
I can finish this one then. Somebody read 33.
14-year-old girl is evaluated for short stature. She is the shortest in the class since preschool. Development is age appropriate. School performance is average. She is prepubertal and found to have a heart murmur. What is the most appropriate investigation for the diagnosis? Cranial imaging, FSH levels, karyotyping, thyroid function test, and ultrasound scan. If she's the shortest since preschool, it's unlikely to be something related to gonadal hormones, so FSH levels is out.
So what are the possibilities here?
It could be familial or constitutional short stature, and maybe she'll catch up later.
Okay, maybe constitutional short stature. Yeah, is hypothyroidism likely here?
Congenital hypothyroidism is like cretinism is unlikely because the school performance is average.
Yes.
Usually they get mental retardation.
And the developmental age is appropriate.
Yeah.
So what is likely? Constitutional, yes, constitutional short stature is a likely diagnosis. What else? What are other possibilities? So D is completely out.
Growth hormone deficiency.
Turner syndrome.
Hmm?
Turner syndrome.
Sorry, which syndrome?
Turner syndrome.
Turner syndrome. Why do you say it's Turner syndrome?
She's 14 years old and she's pre-pubertal and found to have a heart murmur.
Yes. So what is the answer if it is Turner syndrome?
Karyotyping.
Yeah, it's probably karyotyping. Yeah? So if it is a constitutional short stature, you probably would go for
With parental height.
next. What in the out of these answers? Exclude the cranial pathology, no? So you go for cranial imaging. So I think here is Turner syndrome with the murmur, heart murmur, and the karyotyping is the answers.
So Turner syndrome is associated with coarctation of aorta. What murmurs is Turner syndrome associated?
Yeah, I can't remember. I think it's associated murmur. I can't remember what it is. You have to go through the
Okay. Okay.
find out.
It's associated with coarctation of aorta, but it
Yeah,
doesn't
that's
cause a murmur.
What is the karyotyping abdominal in Turners?
XO.
XO, yes. XO.
එතනින් නවත්තෝනේ. Other day, I will put in the chat the next time. Thank you, guys.
Thank you, sir.
Very much, sir.
Thank you, sir. Thank you very much.
Thank you, sir.
Thank you. Thank you very much, sir.